Hello everybody and welcome to today's Connect and Learn webinar. Today's webinar is a part of a series of 10 Connect and Learn webinars designed to support AOD clinicians throughout regional and metropolitan Victoria. It's hosted by Turning Point and funded by the Department of Health and Human Services here in Victoria. So my name is Sheridan and I'll be facilitating today's webinar. Before I continue, I'd like to stop to acknowledge the traditional owners of the land upon which we meet today, the Wurundjeri people, and where the webinar is being presented. And we'd like to acknowledge the elders, both past, present and emerging. So this webinar will explore both the evidence-based practice of research and practice-based evidence, so clinicians and client experiences, in support of working with clients in recovery. So there'll be some case studies and some research as well as discussions about some lived experiences. So it'll compare and contrast definitions of recovery, provide evidence in support of the concept of in recovery and examine what it means to work under a recovery-based practice umbrella. So before we get started, just a reminder that the webinar will run for around 45 minutes. We like our webinars to be as interactive as possible, so you will get an opportunity a couple of times throughout today's webinar to respond. First of all, there'll be some online polls that we really would encourage you to participate in, and there will be a discussion towards the end, and then at the very end we'll take questions. So do engage. You'll see a chat box down the bottom left hand side of your screen. So if you've got some questions or comments that you want to send through, go ahead and type those into the chat box, and then what I'll do is I'll be collecting those and then I'll be presenting those to Naomi to answer for you at the end. Also, just to let you know, there is a PDF version of the PowerPoints from today, and they'll be available for you in the folder that's on the right-hand corner of your screen, so you can go ahead and download those as well. And there's also a PDF resource that Naomi will speak about later, a recovery resource that you can also download as well. If you do have technical problems during this webinar, Redback will be able to help you out there, and their numbers on the bottom of your screen as well. But you'll also be able to see, if you pop it into the chat box, they'll also be able to communicate with you and help you out along the way. So I'd like to introduce you, I'm delighted to introduce the speaker for today, Dr. Naomi Crafty, who is presenting. Dr. Naomi Crafty is a Senior Research Education Fellow at Turning Point, where she manages the workforce development area, which means she is my boss. So with a background in counselling psychology, Naomi has a particular interest in counselling approaches, client engagement, the client-clinician relationship and recovery. Naomi also co-facilitates a unit on recovery in the Masters of Addictive Behaviour. So I think that's it for now, and so I'd love to hand over to Naomi.
Thank you, Sheridan, and thank you everybody for joining us for this webinar. I became interested in the area of recovery when I started at Turning Point about 6 years ago. And I had the pleasure of hearing Professor David Best talk about recovery. He's certainly a very highly engaging and highly motivated speaker about recovery, which and he talked about the recovery movement, which I like to say he brought with him from the UK at that time. And it was quite eye-opening for me and quite a new area or a new way of looking at the work that we do as counsellors or clinicians, because up until that time I've been very focused on what is it that we actually do during that 1 hour of counselling where we work with our clients and what works in the counselling session. And after a counselling session was finished, I'd be thinking, well, what am I going to do next week in next week's counselling session? And the recovery perspective forced me to think about or shift my focus to what is the client going to do in the 167 other hours every week that they are not seeing me. And that was a really important shift in focus and has made me think quite a lot about what we do as counsellors and clinicians. So in the webinar today, we're going to talk a little bit about what recovery is, some definitions of recovery. I'm going to present you some of the evidence in support of a recovery movement, And then we're going to look at the recovery-based practice guidelines that myself and some colleagues at Turning Point and Shark have put together, and how we can use those guidelines to improve the work that we do in our clinical practice with clients. Sorry, I'm going the wrong way. Okay. So it's quite important to put recovery into some sort of context, and people who know me well know that I like to talk quite a lot about historical context and wouldn't have the time to do that today. But I just want to let people know that the recovery movement didn't just spring out of nowhere. It's not as if all of a sudden people started talking about recovery, started talking about the importance of peers in recovery. There are a whole range of things that were happening, if you like, simultaneously. There was a zeitgeist that existed around starting probably in the 60s, 70s and progressing from that time with the movement of positive psychology, focusing on strengths rather than deficits, similar movement in the criminology field, the idea of therapeutic jurisprudence, that the idea that what happens in the court process has a great impact on people who go through that process. The anti-psychiatry movement, which I could talk about for ages, is a really fascinating area. I'm happy to provide people with references about the anti-psychiatry movement if anyone would like those. Then, of course, the recovery movement gained focus in the mental health area and subsequently was taken on board by the drug and alcohol sector. In particular, focusing on the importance of mutual aid groups like AA, for example, in recovery, and really sort of emphasising the importance of peer support in people's journey to recovery. So all these things were sort of happening simultaneously, and it's sort of not surprising then that people started talking about the notion of recovery as a sort of philosophical way of looking at people's journey. So there are a range of recovery definitions that different experts from different countries have provided. The first one was provided by the Betty Ford Institute in the US, and these are certainly in the AOD sector, over 10 years ago. And the Betty Ford Institute talked about a voluntarily maintained lifestyle characterised by sobriety, personal health and citizenship. And there are various forms of that definition that have continued in the UK, and in Australia, Annex in 2012, the definition at the bottom of your screen, talked about recovery as a voluntary, self-determined process toward minimisation or cessation of drug-related harms. This involves fostering healthy supported connections, such as with self, family, peers and community, and is premised upon fair access to prerequisites for well-being. So there's quite a lot sort of within that definition. The idea that to be in recovery, you can be either minimising or ceasing your drug use. You don't have to have ceased drug use to be in recovery. It's about the importance of connections, and connection is a really sort of key word in this whole concept of recovery. Connection with yourself. I really think the idea of self-love, I guess, for want of a better term, or being kind to yourself, I think, and forgiving yourself is a really important concept in recovery. And likewise, connections with families, connections with peers, community, are all vital parts of the road to recovery. And I think the last part of the definition, which is unique to this definition, about giving everyone access to the opportunities and the resources that they need for recovery, which of course is really important and doesn't always happen, unfortunately. Lived experience is really vital to the whole concept of recovery. The importance of client focus and listening to the lived experience of our clients, and of clients being the expert of their own lives. So it's not surprising that there are lived experience definitions of recovery as well. Deegan in 1998 said, recovery refers to the lived experience of people as they accept and overcome the challenge of disability. They experience themselves as recovering a new sense of self and a purpose within and beyond the limits of disability. And Michael Savage, who works with me in this area at Turning Point, he and I, our favourite definition of course is this one by Valentine: you are in recovery if you say you are. And I think most people who work from a recovery perspective are happy with that definition from the client perspective. So now we're going to have the first of our polls. And the question that I'd like to ask you is, what percentage of people do you think make a full recovery from drug and alcohol use? And you have three options there: 7%, 33%, and 58%. Oh, straight away we got a lot of 33%. Yeah.
That was pretty, people are pretty clear.
Yeah. And people are still responding. Okay, we'll stop the poll there. So that's an interesting response. We've got 22% of people who say 7%. We've got 55%, so just over half of people saying 33%, and 22% who say 58%. So let's see where we get those figures from and what those figures mean. So if we look here at those different responses, 7%. Who do you think would say that 7% of people get better from drug and alcohol use? And the answer is, if Welsh workers say that. So if you said 7%, you are in line with Welsh AOD workers who, in a similar study, who asked a similar question, and 7% of them said that about 7% of their clients get better. If you were a client going to a service and your worker, your drug and alcohol worker, thought that only 7% of people were going to get better, what do you think that would mean for your well-being? I think it would be a pretty pessimistic view for somebody to take if they believed that only 7% of people they saw were going to get better. So really it's important that drug and alcohol workers instill hope in their clients, and so they need to believe that the figures are actually better than that. So then if we have a look at the 33%, which we had the majority of people in our poll said 33%, it's not surprising, because in a study in 2014, Amy Pillay found that that's what Australian workers estimate in terms of the percentage of people that are going to get better. So I'm assuming that we have the majority of Australian AOD workers who are responding to our poll, and just like in Pillay's study, you believe that about 33% of people will recover from drug and alcohol problems. However, if we go on to the next amount, C is arguably the correct answer. When we do a meta-analysis of all the research studies that have looked at how many people recover from drug and alcohol problems, the average is around 58%. So we actually do a lot better than a lot of average is around 58%. So we actually do a lot better than a lot of people who work in the sector think. And so just giving workers this information, I think, is really important for them to be able to say, well, hey, you know, nearly 2/3 of people that we see in our clinical work do fully recover from drug and alcohol problems, and we see probably the most complex cases and the most difficult cases. So if nearly 60% of those people are getting better, then the figure in the general community is likely to be much higher. So a really important lesson from this poll is that we need to be a bit more optimistic and convey that optimism to our clients about the number of people that recover from drug and alcohol problems. So from a recovery perspective, there are a whole range of resources that people can draw upon to help in their recovery, and we tend to divide those resources into internal resources or resources that are intrinsic to the individual, and then external resources, things that they can use in the external environment to help in their recovery. So some of the internal resources, certainly some of the things that you'll see there are things that are standard counselling practices. So we know that it's really important from a counselling perspective that we provide people with coping strategies, that we take into consideration their cultural beliefs and ethnographic concepts, that we give them a feeling of self-worth, for example. But there are some areas there like motivation, hope, the importance of lived experience, using their lived experience to provide them with a context for their journey and a meaning to their journey, that I think are sort of unique to the recovery perspective. And certainly from a sort of classic or traditional counselling viewpoint, we don't tend to look a lot at what external resources are available for people. We tend to sort of spend an hour with them and then send them out into the world without really considering their social networks, their family dynamics, education, employment, housing, their sort of basic needs. And of course, over the last 10 to 20 years, we've become to realise that these things are really vital to a full recovery and that they need to be considered within the counselling or clinical context as well. So one way that we can look at that, a model of recovery that was put together by Best and Laudate in 2010, looks at the idea of recovery capital, the idea that we are providing people with the capital that they require in order to recover, and that this recovery capital is made up of personal, social and collective capital. The personal capital, like the slide that you saw previously, is around those internal resources that people have. The social capital are friends and family and peers and those connections in our lives that are really important. And the collective recovery capital are those aspects of a person's environment, education, employment, housing that people require in order to live a meaningful and useful life. Another model that is really important in the recovery area is the CHIME model. So CHIME is the acronym that stands for the points of the star: connectedness, hope, identity, meaning and empowerment. And the CHIME recovery model comes directly from the mental health recovery movements. And it provides a sort of a way of remembering those areas that we can use to help clients in their recovery. So if we start with connectedness is a really vital part of recovery. And this is a study that was done in 2010 that showed that forming new social relationships are as good as giving up smoking for your health, and we all know how good giving up smoking is. So in fact, the addition of just one abstinent person in a person's social network increases the probability of abstinence for the next year by 27%, which is really a massive amount. So Litt and others conducted a study. They randomised participants to two groups. One group were provided network support, so there was really work done to make sure that they gained people in their support network who were abstinent from drug use, or case management, which was treatment as usual. And they found that if you just add one person to your social network that is abstinent, in the next year it has a massive impact on your recovery over that time. So this was a really important study, looking at the importance of connectedness. There have been a range of studies that have been done, a number of them in the UK, and there have been some studies done in Scotland that found that quality of life for people who had drug and alcohol problems improved greatly when they spent more time with other people who were in recovery, and they spent more time during the week engaging in a range of activities that we would consider perhaps meaningful activities. So that includes things like childcare, being involved in community groups, volunteering activity, some sort of education or training or employment. So this graph here shows different quality of life domains from the WHO-QOL. So the physical health domains, the psychological health domains, social relationships and the environment. And it has 3 bars for each of those quality of life domains. One is the norm for the general community, so people who don't necessarily have a drug and alcohol problem. What's the norm in the community, the norm quality of life score? What's the score for people in early recovery? That's the pink or red bar there. And the yellow bar is the bar for people who have been in stable recovery. I believe it was for around 12 months. And you can see there that for people who are just in the stages of early recovery, their quality of life was a bit below the norm. But once they had been in recovery for about 12 months, those bars go above normal. So we actually talk about the fact that often when people have had a situation where they've experienced adversity and then they recover, they actually feel better than normal. And I think this graph sort of illustrates what better than normal might look like. So in particular, in terms of their people's social relationships and their environmental aspects, their access to housing and jobs, etc. People who had been through recovery and were now in stable recovery were doing even better than the norm for the community, which is really great. This graph, or this figure here, is quite busy, and you don't really need to look at it in detail. But I think the title says it all: the personal, social and functional growth as a result of joining a choir for disadvantaged adults. And so if any of you have seen the Choir of Hard Knocks or similar documentaries, you'll know that being involved in that type of activity is really fantastic for helping people who have either drug and alcohol or mental health problems. And this study by Dingle, who's in Queensland in 2013, was really just a way of empirically showing that to be true. And she found improvement in a whole range of areas for people that joined a choir and stuck around in that choir for a period of time. So she measured a whole range of things at time 1 and then at 6 months and then 12 months down the track, and she found improvement in a range of measures, including health, employment and structure. Some of you might be familiar with the concept of assertive referral and linkage. So this is an important thing that we can do when we work in people from a recovery perspective. This original study has been around a long time, since 1981, And it was a study where there were 20 outpatients from a drug and alcohol unit, and approximately half of them were given a standard referral, and the standard referral was, here's a card, go to your local AA meeting, and good luck. And the intensive referral was where a phone call was made to somebody who, from that local AA group, and said, will you come and pick this person up and take them along to the meeting? And you can see the difference there. In the standard referral, no one ended up attending the AA meeting, and in the intensive referral, there was a 100% attendance rate. Our very own Vic Manning from Turning Point has conducted a similar study more recently, and found that still holds, that assertive referral actually help getting somebody to pick somebody up and take them along to a meeting, or taking them along yourself, is really important in terms of getting people connected into a peer group like AA or similar group. So let's have a look at what we can do as far as instilling hope in people. So it's really important that when you describe the glass to your clients, you talk about it as being half full rather than half empty. So we know that doing things like focusing on strengths, giving people statistics like the majority of people who attend drug and alcohol counselling are in fact going to get better. Providing that sort of information is really important for clients, and really praising them for the little steps that they make in their road to recovery. And this slide here is a study that was done by David Best in 2016, and found that just attending training about recovery made clinicians more hopeful and more able to provide hopeful information to their clients. So I hope just by watching today, you're learning something about recovery, and you're going to go away and be more optimistic when you talk to your clients. Let's think now about identity. So how we identify ourselves, what we think about ourselves, is really important. So it's important that our clients develop identity as people who are worthy in their own right, and aren't identified as drug addicts or people that don't have any sort of meaningful relationships, or don't have a good feelings of self-worth, but that they identify as people who are important, that have something to offer society, and who are involved in a range of activities, and not solely identified according to their drug use. So this is based on another study by David Best, and if you have a look at those three little seesaws there, you can see that when a person is actively using drugs, most of their social identity comes from their using group, from the group of people that they hang out with, most of whom are using drugs. And they might have family and other friends from their days before they've been using drugs who might be around in their lives, but they're certainly not as important in their lives. Then at the early stage of recovery, the importance of that using group shrinks, and the number of people in their non-using groups grows, or we certainly work towards that happening. And then when a person is in stable recovery, then hopefully the non-using group are far more important and significant in the person's life, and the using group becomes perhaps a distant memory, and they can continue in their lives. So this is a map of community groups in the Dandenong area, and so this was developed by some people who were doing some research at Turning Point, and using these sorts of maps of various activities, it's possible to actually link people in with different types of support groups. So it was found that there were more than 90 community groups in the Dandenong area, and all sorts of different groups, including recovery groups, sporting clubs and so on. And if you have maps of what's available in your local area, then you can use that information to provide links for your clients into those particular types of groups. So if we talk now about meaning, so here is another study, the results of another study, again using the WHO crawl, that showed that the blue line, the blue bar there is for people who ceased doing activities because of their drug use. The red line is quality of life for people who, over a period of time, were not engaged in a whole range of activities. And the green line shows when they were engaged in activities, both at baseline and follow-up, and purple commenced activities. So people who were not previously engaged in activities and then were encouraged to be involved in activities, could be the choir, could be sporting groups, could be whatever activity they found useful, their quality of life either matched or exceeded the quality of life for people who had been involved in activities right through the period of the study. So it really shows the importance of linking people into meaningful activity. And finally, if we're looking at our time recovery model, it's important that we provide a sense of empowerment to our clients. And so we know that by facilitating access to treatment, to making sure that their basic and urgent needs are met, by addressing their drug and alcohol problems, their co-occurring physical and psychosocial problems, by building strengths and skills, we can help lead a person towards long-term recovery. And it's the recovery capital that happens at the sort of after the early recovery phase, getting people involved in meaningful activities, managing the relapses, all those things that happen as the journey continues past the early recovery phase. So I'd like to just talk a little bit now about a great resource that we've put together with Turning Point and Shark. It's Recovery, a practical guide for clinicians, frontline workers and the family of people with problematic substance use and consumers. And this guide, you can download it from for those of you who are logged on to the webinar. But for those of you who are watching this at another time, you can find it as part of the Department of Health and Human Services website, where they've put information about ice use from NCETA. And this was a great project to put this guide together. We put the guide together with the help of clinicians and with clients who had a lived experience. And I've just put one of the quotes from one of the clients that we talked to, just to give you a feel for some of the information that's in this guide. There was this fear that I'd lost any spark for life until that day where I laughed, that whole belly laugh where you bend over and you feel it and you get tears in your eyes. I thought I would never, ever, ever get that back. And the first day that I did that, that was one of the main points when I was like, okay, I feel like something's changing. I'm getting a little bit of me back. And there's been lots of moments like that. And this guide and the client stories that go with this guide are really uplifting, like that particular quote is, I think. So here's our second poll. What do you think is the key role of an AOD worker in relation to recovery? So you've got three options there. Bridging capital to other professionals and to community resources, monitoring a client and keeping them on track to achieve their goals, or promoting abstinence wherever possible. Hooray! Hooray! I think most of you get what we're talking about. So, still some people still responding. Let's stop the poll now. So 80% of you gave the correct answer. The key role of an AOD worker in relation to recovery is providing bridging capital to other professionals and to community resources. So the role of the worker from a recovery perspective, we've talked about hope, engendering the belief that recovery is possible, building recovery capital, linking to communities, and providing bridging capital to other professionals and community resources. So that's what we do when we work from a recovery perspective. So the main focus in the clinical guidelines that we put together between Turning Point and Shark, we use the SAMHSA guiding principles that are on your screen now, and we gave those guiding principles around recovery to a group of AOD clinicians, and we said to them, if you are working from a recovery-based perspective, what is it that you do that demonstrates each of these guiding principles? And there are lots of examples in the guide, but I'm just going to take you through some of them on the screen now. So if you were looking at the fact that recovery emerges from hope, really important that you emphasise your client's achievements and successes and use affirmative language. We know that recovery is person-driven, so we need to ask the client about their lives and recognise that each journey is going to be different, and ask them to provide suggestions about how they're going to proceed in their journey. We know that there are many paths to recovery, and before that there are many paths to what brings a client to a service in the first place. So we need to find out from the clients what their journey has been up until the point that they see you, and then help them with their journey from that point onwards. We know that recovery is holistic. Doesn't mean that we have to focus on every part of a person's life at once. We can start with one or two areas and then work with others, but we need to think of the self as being someone who's made up of a whole range of, there are a whole range of things that are important in a person's life to focus on, not just, of course, their drug use. We know that recovery is supported by peers and allies. We know that recovery is supported by peers and allies, and we know that recovery can be contagious. You can catch recovery from a peer who has recovered. So it's really important to link people in with people who have a similar experience and are able to help them on that recovery journey. We know that relationships and social networks are really important to recovery. So it's important where possible to try and help people connect with family and friends. But I think this quote that a clinician made is really important. It doesn't make sense to put hurt people in a room and expect them to work it out for themselves. So sometimes it's just not going to work to connect people with family and friends, but certainly clinicians can play an important role in trying to build those relationships where they've been damaged. We know that we need to think about culture in terms of what is normal within the community that the individual lives in, and excuse me, it's important that we talk to people about how their drug and alcohol use is seen within their community, and work with them from that particular perspective. We know that underlying a lot of drug and alcohol use is trauma, and so services and supports should be trauma informed to foster safety and trust. And we've talked a little bit about the importance of strengths, individual, family and community strengths. So doing a strengths assessment, what factors are available within the individual, within the environment, within the community that the person lives in that can help them with their recovery. Recovery is based on respect, so language is a really important part of recovery, so it's really important that we use the right language, a positive language, a hopeful language, an optimistic language, language without jargon in the work that we do with clients. So perhaps I can hear from some of you guys about things that could be done in your service to increase client empowerment. Would anyone like to tell me maybe things that you're already doing that are examples of recovery, like that we've already spoken about? Okay, shall we move on? And maybe you can think about those things and maybe take that question back. Take that question back to your service and think about ways that your service can work from a more recovery-oriented perspective. So I think it's important that I like this little sort of moniker, if you like, that we think about recovery as the fact that everyone can recover. We know that not everyone will, but given that we don't know who will and who won't, we need to give everyone a chance to recover. And so we should take that perspective when we work with clients. And in the guide that you are able to download, there's a lovely story from our friend Garth. Garth is somebody with a lived experience who is now a clinician who very kindly contributed his story and his experience as both a client and a clinician to putting together our recovery guide. And you can see in this story, which I'll let you read yourself, that there are lots of examples of where he sort of worked from a recovery perspective. He got to the point where he felt like he had two choices in life. He was either going to kill himself or he was going to do something about it. And he decided to do something about it. He had a reason to live, which was that he had some nieces. He wanted to see them grow up. So he made a conscious decision to start on his recovery journey. Then the first thing he did was he cut off from his relationships with other people that were using drugs. And of course that was really difficult because that had been his whole community. That was where he had a sense of connection from. So then there was no one. So he went to counselling at that point, and counselling was an opportunity for him to re-engage with things that he liked doing, like painting, for example. And he also made a decision at that point to re-engage with his family. He went back to uni. He got out of Sydney because Sydney was where there were a lot of triggers, and Sydney was where his connections with people who used drugs were. And he lived for 4 years with his brother, I think it was, and his nieces, who were, able to provide him with that meaning in life that was really important for him. So he replaced what methamphetamine had given him with a family experience. And, you can see through this journey that he was really using a lot of the ideas that we talked about as far as building his own personal and social recovery capital through his life. And I'd just like to end by thanking The people who I've worked with at Turning Point in this area, Dr. Michael Savage, Dr. Kelly Matthews, who helped put the recovery guidelines together with Bella Anderson and the reference group and clinical consultants on the recovery project, and all the peers and clinicians, and particularly Garth, who contributed to this project. So thank you all very much for listening.
Okay, thank you so much, Naomi. That was so interesting. I did want to just go back because we did have somebody come through after we'd moved on from the slide that was around the discussion. And if it's okay for me to read, one person has sent something through. If it's okay for me to read to you, Naomi, and you can respond if you like. But James actually responded and says, I actually think that this kind of training about recovery should be mandatory for people who work in emergency services. They have a lot of really unwell people, and it would seem really easy for them to lose hope. And so James, I suppose it's more a comment, but I thought I'd throw it to you just to see if you did want to make a response to what James is saying.
I agree, and I think if we think back to that slide, which I don't think we need to show you because it's pretty straightforward, but the slide that David showed, that attending training on recovery is really important to understand that there's research that actually shows that these things work, that we all know that, especially I'm sure when you work in a sort of an emergency department or in a critical care area, that you see people at their worst and you don't get an opportunity to follow them through their journey to recovery. And even those of us who are privileged enough to work in a counselling or clinical area, unfortunately people are sometimes limited by the number of sessions they can attend, or are certainly able to fly off and spread their wings on their own without needing us after a period of time, and we don't always see where the journey ends. So having an opportunity to think about the successes and the fact that the majority of people do get better, and that we can help make an impact, I think that's a really important thing for us all to do, and I'm sure emergency department staff as well, and very happy if any emergency department staff would like to invite me to come and talk about recovery. I'd be very happy to do that.
Excellent. Okay. So I'll just read. There's just one more question that's come through. So we've just got a few more minutes. So if you did want to ask a question of Naomi while we've got Naomi here, do pop them into the chat box, and I'm collecting them on my screen. So we have a question that's come through. Some people believe that recovery is incompatible with a harm reduction approach. Naomi, how do you respond to this belief?
Yeah, well, that's certainly when David Best first came to Melbourne about 7 or 8 years ago and started talking about recovery. As everyone who's watching, I'm sure, is aware, here, certainly in Australia and here in Victoria, we work from a harm minimisation perspective. And there are a lot of people who believe that recovery was incompatible with that, because the idea that you really needed to be abstinent in order to be in recovery. I think we've become a little bit more sophisticated than that, a little bit more nuanced, and we know that we're really looking at the client perspective in recovery. And I go back to that statement I said, a person is in recovery if they say they are. So if you're working with a client and the client talks about their recovery journey, we can still use harm minimisation techniques, particularly at the early stages of recovery, when it might be helpful to someone. And if someone makes a decision that they want to minimise their drug use rather than be abstinent, that's still part of that recovery journey. And I think recovery is certainly able to accept anywhere along that continuum that a person might be prepared to go or want to go for their own, making that decision for themselves.
Thank you. Okay, thank you. All right, just a few seconds left if anybody has any questions. Just want to give a shout out to Windana, who have just said thank you so much for a great presentation. So I'm not sure who that is, but from Windana.
Thanks, Dana.
Thanks, Windana. Love your work. All right, so if there's no more questions, we might just wrap up there. But before we go, I just wanted to say thank you so much to Naomi for taking your time out of your busy day to come and present this really, really interesting webinar for us today. I'll just, actually one question just coming through. Okay, yeah. So James is saying, I've found being trained in SMART model one of the most useful experiences. This has been a great experience also. All right, so that's beautiful. Thanks so much, James. So thank you so much for tuning in today. So thank you to everyone from Webinar Land for being a part of the live audience for us today. Don't forget to download your PowerPoints and the recovery PDF that's there. And just before we go, I wanted to let you know about our next Connect and Learn webinar. And the title is The Role of Risk in Adolescent Development, Young People and Drug Use, presented by Jeff Balden, who is a Senior Trainer and Practice Consultant at YSAS. So that one is going to be on the 19th of September. You should be able to, you can register through Eventbrite, and VADA are now sending that through on, it's now, the link is now live and it's being sent around on the VADA e-news. So make sure that you sign up for that. Thank you again so much, Naomi, and thank you for everybody for everybody tuning in, and we will see you next time.
Thank you.